Hello everyone, welcome back to YouTube channel Exploring Medico. So today we are going to discuss the important section on the medicine, a part of pulmonology. In the earlier session we have already discussed the respiratory failure. In today's session we are going to discuss another important topic, that is pulmonary function test, because there is an important aspect to evaluate the various diseases at the respiratory level and used by most of pulmonologists and physicians to overcome the treatment of the disease. In case of the doubt, you can use the comment section and you can directly use this PPT for your exam preparations, for your competitive exams or any state level exams. And I hope that this session will be proven helpful to you. Okay, so let's begin. So first thing is spirometry. The pulmonary function test begins with the spirometry. Now let's see what is done in that. In a spirometry test, patient has to breathe into a mouthpiece that is connected to an instrument known as spirometer. From that only it is known as spirometry. And the spirometry records the amount and the rate of air, that patient breathe and out over a period of time. So you can see in the figure, this is how a patient is given a deep breath and blows hard as possible, clip on the nose, and at the same time machine records is the respiratory test. This is how spirometry is done. The patient is asked to take the deepest breath they can and then exhale into the sensor as hard as possible and as long for the preferable at least for the 6 seconds. The ideal time recorded is for 6 seconds. And the test is repeated in the bronchodilator nebulization in the patient of asthma or COPD. Now what are the indications or in which condition you should go for a spirometry? So first is to establish a baseline lung function. If you want to check, you can go for the spirometry. Evaluate dyspnea, that is shortness of breath, to detect any kind of pulmonary disease. Monitor effects of therapies used to treat the respiratory disease. So in the asthma or in the COPD, various treatments are done to check whether that is proven helpful or not to a patient, whether the condition is improving or not. You can go for the spirometry. Evaluate respiratory impairment. What is respiratory impairment? Like there are a various number of medical conditions associated which can affect the respiratory system. Evaluate the operative risk and performance surveillance for occupational related lung disease. And in all this case, you can go for spirometry. Clear? Now we will discuss the contraindications, in which conditions you should not go. First is the hemoptysis of unknown origin. So if you find that patient is having coughing of blood, in that case you should not go for spirometry. In the pneumothorax, when there is a collapse of lungs, because at that time the patient won't be able to hold the breath. Unstable angina pectoris, because it can even lead to many cardiovascular conditions. It can precipitate. Recent myocardial infarction, any kind of thoracic aneurysms or abdominal aneurysm. What is abdominal aneurysms? Like you know that enlargement of aorta, because it is the main blood vessels that delivers to the entire body and it enlarges at the level of abdomen. And next is cerebral aneurysm, that is the bulging in blood vessels in the brain where it protrude outwards. Any recent eye surgery in which intraocular pressure is increased during forced expiration, or any abdominal or thoracic surgical procedures. Or patient with the history of syncope associated with forced exhalation, where the patient is not in the state of consciousness. In these all conditions you should not go for spirometry. Now we will discuss some of the pulmonary function test, a normal basic which you will learn. First is FEV1, that is forced expiratory volume. In the first second, the total volume of air a patient is able to exhale in a first second during maximal effort. So when the patient is doing his maximal effort in the very first second, and whatever the measured is known as FEV1. Now when there is any kind of obstructive lung disease, you will find it will be moderately to severely decrease in the ratio of FEV1, and when there is a restrictive lung disease, you will find a moderately decrease in the disease. Now, what is obstructive and restrictive? Obstructive means what? Restricted airflow and breathing problems like COPD and all, where there is a restricted airflow. And in the restrictive, there is a decrease in the total volume of air, due to which lungs are unable to hold. Total volume of air, the lungs unable to hold. That ratio decreases in the restrictive lung disease. There is a difference. Clear? Now, what is FVC? Forced vital capacity. That is amount of air exhaled forcefully, total volume of air a patient is able to exhale for the total duration of the test during maximal effort. So when the spirometry is going on the entire test, when the patient is doing his maximal effort to exhale out, that we will term as FVC, forced vital capacity. When there is obstructive lung disease, you will find it moderately decreased, it could be normal, and when there is restrictive lung disease, you will find that mildly to severely decreased FVC ratio. Next is FEV1 to FVC ratio. It is the percentage of FVC expired in 1 second. So when there is FVC expired in 1 second, it will be termed as FEV1 to FVC ratio. It can also be known as FEV1 ratio and is also known as Stephenio-Pinelli index. Now, this is not useful when FEV1 and FVC both are normal. At that time, this ratio is not clinically helpful. In the obstructive lung disease, you will find it moderately to severely decrease in the ratio of FEV1 to FVC, and in the restrictive, it can be normal, or you will find the ratio to be increased. So remember that in the obstructive, the ratio will decrease, while in restrictive, the ratio will increase. What is the vital capacity? That is total lung capacity minus residual volume, that we all know. What is residual volume? Volume present in lungs after maximum expiration, when there is a forceful expiration, and whatever the amount of the air is present, that is RV. And in the obstructive lung disease, it will be increased, while in the restrictive lung disease, it will be decreased. It is clinically helpful. So remember that in the ratio, you will find opposite. In the obstructive, it will decrease, while in the obstructive, residual volume will increase. So these data are clinically helpful, and you should remember very well, because it will help you to clinically correlate the state of the disease. Next is total lung capacity, where volume of gas present in lungs after maximum expiration, that is the total lung capacity. So in the obstructive lung disease, it will be normal or mild child, while in the restrictive lung disease, the ratio will decrease, that is TLC, because we have seen in the capacity already, we see. Now PEF is what? Peak, that is maximum expiratory flow. You can go for this test also, that is the highest expiratory flow in the seconds. And next is FRC, that is the functional residual capacity. What is it? Volume gas in the lungs at the end of normal exhalation. So when is forceful exhalation, at that time you will go for TLC, and when there is a normal exhalation, you will go for FRC. Clear? And what is FEF? Forced expiratory flow, that is between the 25% to 75% of the vital capacity. MME or MEF, that is the maximal mild expiratory flow, and this is the peak of expiratory flow taken from the flow volume curve and measured in liters per second. This is how measured, that is the highest expiratory flow in the peak, which is measured in a flow volume curve. It should theoretically be identical to peak expiratory flow. You will find similar to PEF, which is however generally measured by a peak flow meter and also given in liters per minute. Recent research suggests that the reduced FEF 25 to 75% or MMEF may be more sensitive parameter than FEV1 in the detection of obstructive small airway disease. So whenever any kind of obstructive disease are there, at that time MME ratio is, or MEF ratio is more helpful than FEV1 ratio. Clear? Bronchodilator response or significant values. Response suggests reversible component. That is, reversibility is a feature of asthma. So where you can give the correct treatment on correct time. At that time there is a chances of the reversible component of asthma. Or FVC or FEV1 improves by 12 to 15% over the baseline when there is a bronchodilate response. Or FEV1 is increases by at least of the 200 ml. Or FEF 25 to 75 improves by 15 to 20% over the baseline. So following are the right choices or right treatment in the bronchodilator response. Or diffusing capacity, DLCO. In the reversible obstructive lung disease, you will find as asthma, that is normal, while in the irreversible obstructive lung disease, that is the COPD, you will find the level of the DLCO low. So these are all the various clinical parameters that is helpful. And the DLCO is the measurement of the rate of transfer of a gas from the alveolus to hemoglobin in the capillary, at the level of capillary. Clear? And it measures the transfer of gas and also in the red blood cell in the lung blood vessels, because it is a part of pulmonary function test to determine overall ability of the lung to transport gas into and out of the blood, that is DLCO. Next, altered PFT. Now in which cases you will find spirometry test? When there is obstructive lung disease, what will be the spirometry clinical evaluation? FEV1 will be very low. You will find the ratio is also low. Total lung capacity can be normal or high. Residual volume will be high and viral capacity will be low. So these are the clinical parameters which you should remember. On the basis of this, you will be able to find whether it is obstructive, restrictive or extraparenchymal restrictive. And this kind of obstructive, what are the examples? Asthma, COPD, bronchiectasis. That is the lung airway become damaged. So it is hard to clear, mucus or cystic fibrosis. Now in the restrictive parenchymal disease, where there is the decrease in the total volume of air that lungs are able to hold, in that FEV1 will be low. Ratio can be normal or high, but TLC, RV and VC, these all things will be found low. Remember that. While in the obstructive it was high, low. Now what are the examples? Sarcoidosis. It's a growth of the tiny collections of the inflammatory cells in the different parts of the body. Or interstitial lung disease, that is or idiopathic pulmonary fibrosis, that is IPF, there is a fibrosis of lung. Or pneumoconiosis, where any kind of disease occurred at the level of the respiratory level by the inhalation of organic or inorganic airborne dust particles or radiation due to ILD. Now extraparenchymal, you will find FEV1 to be low, ratio could be normal, rest all capacity will be low except RV, where it can be normal or it can be low. You will find this in the myasthenia gravis or Guillain-Barré syndrome, where your immune system attacks your nerves. In the muscular dystrophy or any kind of spine injury, chest wall deformity or diaphragmatic paralysis, where there is a nerve involvement. Okay, in these cases you will find altered PFT. So these are clinically helpful. So remember this table. Okay. Now this is the volume time curve found in the pulmonary function test. FVC could be normal here, but FEV1 ratio could be, or FVC normal, all the normal ratios are denoted. When there is a patient of asthma, you will find this ratio to be going this way normally at the peak, and when there is a COPD, then volume time will go like this. So it will in the asthma you will find that it will be moderate to severe normal in the FVC, while in the COPD it will not reach there. Clear? And this is the test result. When there is a 20 years old, you will find this PFT like this. When there is asthma or COPD, you will find this to go inside. So instead of this is a normal In the COPD patient, you will find it bulging inside. This how. In the severe, it will notch like this form. And when there is a stenosis or rare, you will find this like this, where it protrudes from inside. This is the age of 20 year, if any kind of. At the age of 50, you will find this ratio is in the moderate or COPD more bulging inside than 20 years. And in the restrictive diseases like pulmonary fibrosis, from both the side, it will go inside. So this is how there will be the PFT ratio. And in the intrathoracic stenosis, there is a rare condition you will find where the graph will be like this. Remember this because this is also clinically helpful to you. Clear? So this was all about today's session. Thank you. In case of the doubt, please use the comment section, and this are the various tests which is helpful to you at the clinical level. So before starting the next new topic, go through this. Okay. Have a nice day.